We're going to talk about chronic pulmonary embolism. I often get questions about how can you tell between acute and chronic pulmonary emboli. So we'll look at the imaging features of acute and chronic pulmonary emboli in terms of the filling defects. And then we'll also talk about the consequences of chronic PE, particularly chronic thromboembolic pulmonary hypertension. And there are some specific imaging findings to look at for that diagnosis as well. So obviously, we usually encounter pulmonary emboli on CT pulmonary angiograms, but it's something to consider, of course, in oncology patients, and then also in patients with chronic dyspnea, where we may not have contrast. Sometimes we can get a clue based on other imaging findings, so we'll discuss that as well. So let's just start with a case of acute pulmonary emboli. Such as in this case here. So we can see this person has extensive pulmonary emboli. We've got multiple filling defects. They have rounded contours, are in general mostly centrally located within the pulmonary arteries. Here we can see this one has sort of plugged up this segmental artery in the right middle lobe. We have some more down here. Notice that they preferentially are found at bifurcation points. This is probably because they're getting caught at the bifurcation as they're embolized. So again, some of them are nearly occlusive, like here in the left lower lobe, but most of them are not occlusive. But again, they're centrally located within the vessels. They sort of have rounded but convex margins. The vessel size is essentially normal. Sometimes you might even see that they're a little bit dilated, but mostly the vessel size is normal. So this would be acute pulmonary emboli. In this case, we can see that the right ventricle is enlarged compared to the left, so this is evidence of right heart strain. This study was done with dual energy technique, and so we can look at the pulmonary perfusion map and see that there are extensive, this is just artifact, but there are extensive perfusion defects within both lungs. You can see how heterogeneous the perfusion is here. We've got a large area of perfusion defect here in the left lung. Here's a nice wedge-shaped one in the right upper lobe. And as you can kind of see as we scroll throughout this case, there's this extensive perfusion defect, like here, nearly the entire left lower lobe has a perfusion defect. These don't necessarily translate into pulmonary infarcts. They're just perfusion defects. You should be aware, though, that in the setting of acute PE, many pulmonary emboli will not cause perfusion defects because they're non-occlusive, and this simply requires intravenous contrast to pass around the clot, where in contrast to the VQ scan, where you actually have particles, which of course will be stopped by even not totally occlusive clots because of the size of the particle. Now, over time, the pulmonary emboli will resolve. The speed of resolution is quite variable from patient to patient, and the filling defects may resolve within days. They may take months to go away. The speed of resolution doesn't necessarily imply anything. Here we can see this was not a PE study. We can see this patient who had an acute saddle pulmonary embolus approximately like a month prior. We can still see some residual saddle PE here. The filling defects now are somewhat central, but a little bit more adherent to the walls. You can see here is some thrombus along the wall of this vessel here. Again, here we can see some thrombus along the wall. You can see the wall almost looks kind of irregular. It almost looks like atherosclerotic plaque, but it's simply resolving thrombus. You can see here in this posterior basal segmental artery that the artery is sort of partly occluded. It's small, so that is in contrast with acute PE, where the vessel size should be normal or maybe even slightly enlarged. Here the vessel has become small. This is because of the chronic pulmonary embolus that has just sort of caused contraction and scarring of the vessel. You can see that it's much smaller than these adjacent vessels at the same level. On the left side, we can see again some mural filling defects. Here, some of it is still central, but you can see that some of it's starting to adopt these concave margins here. So these are all findings of what we would describe as subacute pulmonary embolism. Now we'll look at another case. And in this patient, let me pull up the prior. So this patient presented with acute pulmonary embolism. Maybe some of it's subacute actually at this point. You can see these filling defects here, right? Multiple bilateral pulmonary emboli. Now, several months later, the patient returns with persistent dyspnea on exertion. And you can see that essentially the pulmonary emboli have resolved. We don't really see any residual filling defects, like there's some lymph nodes here next to the pulmonary arteries, but no convincing filling defects. However, we look on the lung windows, we can see pretty extensive mosaic attenuation as we scroll through. And there are areas, maybe a little bit more apparent on the coronal images here, there are areas of vascular pruning and or at least vasoconstriction. So you can see, for example, here in this area in the right lower lobe, we've got decreased attenuation of the lung parenchyma in this kind of wedge-shaped region here. You can see that here we have several bronchi. You can see the pulmonary artery along this bronchus, pulmonary artery along this bronchus, those are normal. The pulmonary artery along this bronchus is essentially invisible. We don't see it at all. So this is an area of at least vasoconstriction, if not vascular pruning, related to, at this point, at least subacute, if not chronic pulmonary emboli. This study was also done with dual energy, and you can see multiple peripheral wedge-shaped perfusion defects. So these are real, true segmental perfusion defects. Here is the correlate to the one that I was pointing out in the right lower lobe. At this point, the patient did not have evidence of pulmonary hypertension, and so this is an entity that is sometimes referred to as chronic thromboembolic disease, or CTED, rather than CTEPH, CTEPH, which would be with evidence of pulmonary hypertension. These patients may still have symptoms, and the exact management in these cases is unclear. Now, this patient, we'll talk a little bit about management of chronic thromboembolic pulmonary hypertension, but in order for the patients to undergo surgical thrombectomy, there has to be proximal thrombus for the surgeon to remove. In this case, there's no proximal thrombus. So this patient would not be a candidate for surgical intervention, even if they had true pulmonary hypertension. So these sorts of patients you'd have to follow over time to see if these perfusion defects eventually resolve or if this is truly chronic, since it's only been a few months at this point. So now moving to some cases of chronic thromboembolic pulmonary hypertension. So we'll see, first we'll focus on imaging findings of the chronic pulmonary emboli themselves. So here we have mural-based thrombi with relatively concave margins in some areas at least. You can see here they appear to be adherent to the wall. The vessel is, of course, markedly narrowed. We have webs. There are some better examples in this case, but here's one small little web-like filling defect. Here we have another small web-like filling defect. And we'll go to the right side. Got some more webs here. Narrowing of the orifice of this vessel. Again, some nice examples of webs here in the right lung. A small web-like filling defect. You can kind of follow it in that artery from wall to wall. In this case, the entire left lower lobe artery is totally occluded. So there's the thrombus within it. And then we just don't see the left lower lobe artery. Notice that, so here is the corresponding bronchus. Notice that the size of that vessel, even it is occluded, but we can kind of see the size. It's very small compared to, for example, the size of the right lower lobe pulmonary artery here. So vascular pruning is another feature of chronic pulmonary embolism. On lung windows, you can see that there's scarring and volume loss in this part of the lung. There's, of course, also extensive mosaic attenuation within the right lung related to abnormal perfusion here. In some cases, you'll see scarring from sort of chronic ischemia or infarcts that look sort of like discrete nodules. This patient doesn't quite have that, but they do have scarring left lower lobe. Now, the other features of chronic thromboembolic pulmonary hypertension, as far as the pulmonary hypertension part, of course, are going to be in the heart. So you can see here that the right ventricle is enlarged compared to the left with flattening of the interventricular septum. We have right ventricular hypertrophy with thickening of the right ventricular wall. The measurement's not so important here. I'm just pointing out the walls thickening. So if you see these findings, we can also look at the main pulmonary artery here, which is also enlarged compared to the aorta. These findings will suggest to you that the patient has pulmonary hypertension. Obviously, they're going to get echocardiographic and probably even invasive evaluation of their right heart pressures. But even on CT, we can see these findings. And if you see these findings in the setting of chronic PE, you should suggest chronic thromboembolic pulmonary hypertension, or CTEPH, CTEPH, as the diagnosis. In this case, we have a dual energy scan with, again, apologies for the artifact. We can see extensive perfusion abnormalities within both lungs, with essentially absent perfusion to the left lower lobe, as you can see here. We'll go to another example. Here we see there's some narrowing of the right pulmonary artery. And while we have a patent right upper lobe pulmonary artery, the interlobar artery is totally occluded. Here is where it should be. Here's the thrombosed part of the vessel. Again, notice that it's small compared to the contralateral vessels, and just there's completely absent pulmonary perfusion to the right middle and lower lobes. You can see that we've got extensive scarring and fibrosis in these areas of the lung that are ischemic. And then, of course, extensive mosaic attenuation within both lungs. Interestingly, this patient was labeled as potentially having chronic hypersensitivity pneumonitis with a non-contrast study, given the presence of fibrosis and extensive mosaic attenuation. But the clinician astutely observed the patient's pulmonary hypertension was out of proportion, and so they did this PE study which showed the chronic pulmonary embolism. Again, you can see some vascular narrowings. This this branching point here is obviously very asymmetric, with this vessel being much smaller than the vessel proximal to it. Again, here, abnormal branching there, suggesting small webs, basically. In this case, the right ventricle is not enlarged, but this patient does have pulmonary hypertension based on echo. And just one more example here. Chronic PE will occasionally calcify. So here we see this mural filling defect, and I'll show it again on the coronal images. We've got calcifications that you can see here within the thrombus. Again, it's asymmetric or eccentrically located within the vessel. Here again, we've got mural-based thrombus with calcifications. And then here a nice example again of the sort of mural-based and kind of concave or obtuse margins that we can see here. Obviously, abnormal vascular branching here with very, very diminutive or absent right middle lobe artery. We've got some webs again here down in the right lower lobe. Again, a little web right here, web-like filling defect. And you can look on the lung windows and notice, again, the vascular pruning findings. So in the left lower lobe compared to the right lower lobe, you can see that we've got bronchus and corresponding artery. These arteries are enlarged because this patient has consequent pulmonary hypertension. On the left side, we've got very small arteries in the left lower lobe. So this, again, suggests this abnormal or corresponds to the abnormal perfusion, asymmetric and patchy because of the differential involvement of the different vessels by webs and chronic PE. Just to show you the coronal images, I often find very helpful for evaluating central PE. So you can see here these filling defects are clearly mural based within the right and left pulmonary arteries. Much easier to understand their relationship to the pulmonary artery based on the coronal images. Also, sometimes you can miss these if you scroll on the axial images because there will just be no contrast in it, so you won't realize that that's supposed to be part of the pulmonary artery. You'll think it's just mediastinal soft tissue or something. So coronal can show you a lot better the central pulmonary arteries and their relationship. So as I alluded to earlier, in terms of treatment planning, these patients with chronic thromboembolic pulmonary hypertension can actually be treated with surgical thrombectomy, which will actually substantially improve their hemodynamics. Now, in order for a patient to qualify for this treatment, they have to have proximal disease. In other words, main or lobar, generally, filling defects that the surgeons can then directly access when they open the pulmonary arteries. If they don't have any proximal disease, then the surgeons will not be able to do a thrombectomy. With the proximal disease, they grab onto the filling defects and then they're thrombus, and they're able to sort of peel it out, and they're able to go farther distal into the pulmonary circulation. But if there's no proximal disease, then they're not really able to do that. So that's something important to comment on when you report these cases. Now, in addition to CT, we can also do MRI or MRA to evaluate the pulmonary circulation. So we'll take a look at this case of a patient with known chronic PE. You can see this is a non-contrast bright blood sequence, which shows you the pulmonary arteries. You can see there's chronic PE here in the left lower lobe pulmonary artery. You can see some blood signal here, but a lot of surrounding soft tissue, which is chronic thrombus. Here's another slightly better bright blood sequence here. But the real key and the helpful part about MRA is the ability to do perfusion imaging. And so we can look at this. This is a time-resolved MRA using so-called keyhole techniques. So it's Siemens, so it's a twist, but there are corresponding sequences for the different scanners. So this is time-resolved. We have a very high temporal resolution, although poor spatial resolution. And so you can catch the pulmonary perfusion phase, sort of pulmonary capillary phase here. And you can see that there's very heterogeneous perfusion of the lungs, with good perfusion to the right upper lobe, but essentially absent perfusion in the right lower lobe. There's absent perfusion in the apical left upper lobe, and then reduced perfusion in the left lower lobe as well here, but like good perfusion here more anteriorly in the left upper lobe. So this can be an adjunct or replacement for doing VQ scan. And as we saw, you can also obtain this information from dual energy CTs. Now, after the time-resolved MRA, this patient then had a standard MRA sequence in the axial plane where you can actually see the chronic PE itself that we also pointed out on the bright blood non-contrast sequences, but here you can see it here. Sometimes it's more difficult in an MRI because the thrombus has bright T1 signal. But you can see here, this is thrombus. There's the pulmonary artery itself. And it's essentially, the left lower lobe artery is essentially totally occluded. Similarly, the right lower lobe artery here, we've got vascular pruning and essentially absent pulmonary arterial flow here. You can see the proximal right lower lobe pulmonary artery, and then it sort of is thrombosed here. And again, enlarged right ventricle in this patient with known pulmonary hypertension. So we looked at some different imaging techniques. So just to summarize, if you have a patient with PE, acute PE presents with central filling defects that appear like pieces of material that have kind of sausage shapes and convex margins. As the PE starts to resolve, it becomes adherent to the wall. You start seeing concave margins and overall, of course, decrease in size. And you want to remember that not all subacute PE is chronic PE, and it's not all chronic thromboembolic pulmonary hypertension. You really want to see that it's persisting over a number of months and that the patient develops pulmonary hypertension. And again, there's a gray zone, there's a spectrum of patients who have chronic PE, no pulmonary hypertension, but persistent symptoms, which is an entity known as chronic thromboembolic disease, versus the patients who truly develop pulmonary hypertension from chronic PE. And in those patients, you're going to see peripheral or these sort of eccentric filling defects within the pulmonary arteries. They may calcify over time. You'll see webs. You'll see vascular pruning. In other words, fewer vessels in a segment of the lung than you would expect. Mosaic attenuation. If you do perfusion imaging, you'll see perfusion defects. And, of course, the evidence of pulmonary hypertension within the cardiac chambers. And in those patients, it's important to report the proximal extent of disease for surgical planning. In other words, how proximal do you see thrombus? And using the coronal images is very helpful for looking at involvement of the right and left pulmonary arteries.